Okay, hi everybody. Let's see here. Okay, Dr. Rafich here, Vet Triage. It's September 24th, 8:22 a.m. Pacific time, and we're going to talk about spinal tumors in dogs. This is coming from this issue of JAVMA. It's volume 251, number 12, December 15, 2017. We're continuing on reading this journal after yesterday. I put in the description the information for this journal and specifically for this exact article, which is a "What's Your Diagnosis?" And for those who aren't familiar with JAVMA's "What's Your Diagnosis?", they go through a case study, basically that's interesting or rare, to try and help clinicians think about something that they usually don't, that they're not used to seeing, or something outside the usual. And it can be any species, most often small animal. But so in this case, this is a 4-year-old female Labrador Retriever that had a 2-year history of tetraparesis in coordination, and it became progressive over that time period. Then suddenly, over 2 days, the dog was unable to walk. So just for definition purposes, for those who don't know, tetraparesis, so tetra means all four, so all 4 limbs. Paresis is a weakening of the limbs, whereas plegia is paralysis of the limbs. So this is tetraparesis. And the dog also had what we call generalized proprioceptive ataxia. So ataxia is simply an abnormality in ambulation, in the ability to walk. and there are 3 different types of ataxia: cerebellar, vestibular, and proprioceptive. So in this case, it's proprioceptive ataxia. Proprioceptive implies a lack of ability of the body to recognize where the limbs are in space. So whereas vestibular ataxia has to do with the balancing system, right? So the inner ear and the vestibular nerve. And then cerebellar ataxia has to do with the cerebellum. And all 3 of those ataxias have their own characterization in a clinical setting. So a lot of veterinary students and newer vets will have some challenges with this, but when you think of it that way, it's quite straightforward. It takes years of practice, of course, in seeing these cases to know. So this dog has a generalized proprioceptive ataxia, severe ambulatory tetraparesis. So that tells the veterinarian that the problem is in the neck, in the cervical spinal cord. And we usually define that by the spinal cord segments. So the cervical myelopathy, which is what this would be, cervical being neck, myelopathy being a condition of the spinal cord, is C1 to C5. So from the spinal cord segment in the cervical region, number 1 to number 5. And for those who don't know, there are 6 segments in dogs. Okay, now, so they ended up performing a CT myelogram. And for those who have not seen a CT myelogram before, it's this top image. Basically what they're doing is a CAT scan. And then during the CAT scan or computed tomography, they're injecting contrast material dye into the spinal canal, into the spinal cord, or spinal canal rather, and in the subarachnoid space. So the idea there is that when the contrast travels along the spinal cord and the brain, theoretically, it can help us outline whether or not there's a disease that's affecting the spinal cord at all. Is it in the spinal cord, outside the spinal cord? And those are common questions that we have when we perform these studies. Just to give an idea of spinal cord layers, because it's going to matter for this article, the meninges are composed of 3 layers that cover the brain and the spinal cord. And the most superficial layer is the dura. We shorten it to dura, but it's actually dura mater, M-A-T-E-R. And then right beneath that is the arachnoid mater, and then after that is the pia mater. And we usually say dura, arachnoid, and pia, but these are the 3 layers that make up the meninges. And there's space in between these layers as well. Some are space that you only see after death or with disease. Others have a natural space in between them. We don't have to go through all that, but the idea there is that we try to characterize diseases based on where they may be located in the meninges or in the spinal cord, if it's not in the actual spinal cord, or the brain, because those 3 layers cover the brain as well. All right. So when you look at this image here, it's showing there that there is the white arrow on image A pointing to an enlargement of the spinal cord. As you can see, the contrast material in the dorsal column of the spinal cord is attenuated, and that homogeneous attenuation, meaning the dorsal and ventral columns, is pretty typical of something that's considered intramedullary. So intramedullary means intra is inside, medullary is the parenchyma or the meat of it. And so this tells me that there's something in the spinal cord that's causing swelling of the spinal cord. That's opposed to something that's extramedullary, which is outside of the parenchyma or the main tissue you're talking about. And so you can see there's an enlargement of in figure A, and then there's a asterisk there over some white structure there. That's an arachnoid diverticulum. So the contrast material that normally should be confined to the dorsal and ventral columns of the spinal cord is extending beyond that into the space in between the vertebral bones. And in figure B, those two black arrows are showing that there's remodeling of the bone, indicating a primary or secondary condition of the bone in that area. So you want to, when you see all these lesions like this, first of all, it explains why the dog has tetraparesis, and secondly, you kind of want to make it all one disease. It's possible that all three of these findings, the intramedullary swelling, the arachnoid diverticulum, and the bone remodeling, are all separate entities. That's possible, but it's a bit weird coincidence to have all three of those aberrations in the same general vicinity of the neck. So you kind of want to make them all related. Okay, so let's talk about this further. So the dog then went from CAT scan to MRI. Now, MRI, or magnetic resonance imaging, is the same idea as CAT scan, meaning it gives you a three-dimensional view of a structure, but there's pros and cons to both. CT is great because it's usually cheaper, it's faster to perform, requires just minimal sedation for it to be performed. And in most cases, not always. Like, for example, in this case, if you're going to perform a myelogram, which is the injection of the contrast material into the spine, surrounding the spinal canal, you need anesthesia for that. You can't have the patient twitch or move or anything. So they probably did general anesthesia, is my guess, for the CT myelogram. But for MRI, the downfalls to MRI is that it does take longer, it's more expensive, it requires general anesthesia. However, MRI is great for soft tissue, especially in the nervous system, whereas CT is not that great for soft tissue, but it's really good for bone. So that's the difference there. So most folks will start off with CT scan because it's cheaper, more available, faster. And then if that doesn't give you the answer, you go up to an MRI. As a surgeon myself, having this case, I would just go right to MRI if I had that luxury. But MRIs are expensive for a hospital to own. They're not as common as CT scan, but they are the ideal for nervous system issues. So you can see here in the image below, that's the MRI. And if you notice, in C is the most telling. There's a white structure, like an oval shaped structure, fusiform shaped structure there in the actual spinal cord that confirms the intramedullary presence of the disease, and it's contrast enhancing, meaning when we inject contrast into the patient, it lights up this lesion. So there's some sort of smoothly demarcated intramedullary expansive lesion within the spinal cord, causing attenuation of the dorsal and ventral contrast columns. So when you see something like this, you think, okay, that's in the right location with what the dog was showing clinically. Now, what are some differential diagnoses for that lesion? Because that's probably the cause of all this. And if it's not the primary cause of this, it's certainly the most important cause in comparison to the arachnoid diverticulum and the bone remodeling. So differentials include cancer. That's number one. Second is vascular malformation. Third is inflammatory disease. Fourth is infectious disease. And most often in dogs, when we see just this finding and there's no other symptoms or anything, and they're a young adult, cancer becomes number one on the list. But all those are possibilities. So the dog ended up being put to sleep. They didn't want to pursue anything further with the dog, and then they ended up doing an autopsy, where in veterinary professions called necropsy. They diagnosed an intramedullary schwannoma. So a schwannoma is a cancer of the nerve, the lining of nerve roots. And what's interesting about this case is that schwannomas are always involved with peripheral nerves, not central nervous system. So your nervous system is made up of the PNS, which is peripheral nervous system, and the CNS, which is central nervous system. Central nervous system is brain and spinal cord. PNS are all the nerve roots that go from brain and spinal cord. And schwannomas are always peripheral nervous system, never central. And yet here we have a case of the first case that we know of that's been reported for a schwannoma involving the actual CNS. So intraspinal schwannomas in humans and dogs are usually intradural, extramedullary, or extradurally located. So let's just go back to that. We mentioned before the 3 layers of the meninges, the dura, the arachnoid, and the pia. So when you say intradural, it means it's inside the dural layer, and it's extramedullary at the same time because it's outside the spinal cord. Whereas you can also define these lesions as extradurally, which is outside the dura. This is a bit more nuanced than probably folks who are watching this care about, but just to give those who are vet students or newer vets the defining factor. It's important because different diseases will be intradural, extramedullary versus those that are extradural versus those that are intramedullary, and that's why that distinction is important. In humans, intramedullary schwannomas are rare. They account for 0.3% of all intraspinal tumors and 1.1% of intraspinal schwannomas. A male predisposition is reported. It's most often in the cervical spine, 58% of people, followed by thoracic spine, 32%, and lumbar, 10%. In people, they are usually seen as hypointense masses on T1 weighted images with or without an inner isotense area. On T2 weighted, they are usually hyperintense. We're not going to go into details of the different images for MRI, although we could in another video. But the reason why it's glowing is because that's called hyperintensity, and that's contrast enhancing, meaning it was more evident after you gave contrast to the patient, which tells you that basically that there's a blood supply going to that lesion. The absence of Schwann cells, so those are the normal cells, and then when it's a cancer, it's schwannoma. The absence of Schwann cells within the spinal cord is widely accepted, but aberrant proliferation of nerve fibers and Schwann cells, also known as schwannosis, is in the perivascular spaces of the spinal cord has been documented secondary to physical injury and diabetes. And this is in people, again, because it's not been reported in dogs. Other thoughts for the origins of these tumors include those Schwann cells that are located right at the posterior nerve root as they enter the spinal cord. So, like I said, the spinal roots leave the spinal canal, and it's possible that if you have Schwann cells that are abnormal right at that junction, they could potentially climb up into the spinal cord. That's another suggestion. The other hypothesis is that there's a subpial extension of Schwann cells along the perivascular nerve plexus of the spinal cord vessels. What that's saying is the spinal cord vessels also may have Schwann cells that are located there, and subpial means under the pia mater. So that's the very deep layer that's right over the spinal cord or brain. So it's possible that the Schwann cells associated with the vasculature of the spinal cord infiltrate the spine that way. It's possible that these are actually ectopic neural crest cells during embryogenesis. So during the development of an embryo, neural crest cells basically create everything. It's too complex for me to even understand. I've tried. It was all vet school stuff. But any abnormality with the neural crest cells during the formation of the embryo can result in ectopic neural crest cells. And what that means is these cells are located ectopically, meaning away from where they're supposed to be, because of some sort of misdirection chemically, and then you develop abnormal tissue in an abnormal area. Or another hypothesis is that these are Schwann cells that differentiated from multipotential mesenchymal elements of the CNS. Boy, they're really challenging us today with this article. So multipotential implies a cell that has the possible lineage of multiple cell types. So that's common in embryogenesis, so the formation of an embryo. One cell can turn into many different types. That's how we're made. Mesenchymal, multipotential mesenchymal elements of the CNS. So basically, the cells that were supposed to turn into something else turn into Schwann cells, and they end up landing themselves in the spinal cord. Okay, that's a lot. And then there's the subspinal arachnoid diverticula that you can see. That's that fluid-filled swelling over the spine in this dog. That's usually considered a secondary to a progressive compressive myelopathy, and you see it usually in young animals. So diverticula are very rare in dogs, and they are usually congenital, meaning young animals are present at birth due to whatever reason. However, you can have it be a secondary disease as well due to chronic spinal cord compression or inflammation. This dog had a 2-year history of spinal cord compression, which means that it's very likely that the compressive myelopathy, right? So the myelopathy is spinal disease. Compressive means something is pushing on the spinal cord. It over time resulted in this diverticula. Hey, what's up, Daniel Brown? Hi, how are you today? Good morning, New Zealand. Welcome. Yes, my good friend. Hey, man, if you have any questions, let me know. It's good to have you. And then finally, a bone remodeling over C3, C4, C5. So those are the vertebral bones, not the spinal cord segments. Those are the bones, the vertebral bones of that spinal, cervical spinal cord. They could be due to chronic pressure from anything that's expanding in the spinal cord. And so, yeah, you have expansion here, both from the diverticula and from the tumor itself. So schwannomas are histologically benign neoplasms, and good clinical outcomes after gross total resection or subtotal removal is reported in people. So you take these people and maybe even dogs to surgery to remove either all or most of the tumor, you can have a pretty good prognosis because they are considered benign. And schwannomas are interesting because they are considered benign. However, they usually have really deleterious effects on the body because they're always located in areas that are terrible. If you have a schwannoma affecting the nerves of the armpit, it's usually going to end up being an amputation of the limb because of the chronic pain and then eventual nerve dysfunction. But the pain is the big reason. If you have one located in the spinal cord like this, sure, they're benign, but they're also in the spinal cord, which you have to chase it surgically in the spine, which is not always easy to do. It's not easy to do. And in animals, people may not be gung-ho to start that. So even though they're histologically benign, clinically or based on location, they're not that benign. They're actually quite destructive. That's it. That's a good one for today, guys. It's a long live stream. Hopefully gleaned something. Daniel Brown, thanks for being a part of this. Thanks for the 3 folks who joined this live stream, and we'll be back again tomorrow with another journal. We'll continue with this issue of JAVMA. Take care, everybody. Bye.